Okay, hi everyone. This is our lecture for chapter 8, which is fluid and electrolyte imbalances. And just a reminder that you should have that chapter 8 review sheet out and should be taking notes on it as you listen to the lecture. Remember that the first part of that chapter 8 review sheet, there's a list of terms there. You should have all of those terms defined on that review sheet, but then you should also be adding in notes for everything else that I'm talking about in chapter 8 as well. Okay. First learning outcome, right? Describe the normal fluid and electrolyte balance, results of some inappropriate fluid and electrolyte imbalance, and concepts that are related to it. Okay, so this is kind of just the sort of, again, some general information that's going to pertain to the more specific information that I'll cover towards the end of the chapter. Okay, now, this picture here is just pulled from the Unit 3 sort of overview. And so remember, Unit 3 is chapters 8 and 9. So chapter 8 is fluid and electrolyte imbalance, and then chapter 9 is acid-base imbalance. The reason why I'm sort of bringing this up is because we're not going to cover chapter 9, okay? So we're not going to cover acid-base imbalance, but I want to talk a little bit about it, okay? So the first kind of idea is that fluid and electrolyte imbalance will affect acid-base imbalance, okay? And vice versa. So the two really affect each other in a big way, okay? And so that's really why they're, put together in this one unit. And so if you look down here, right, this is showing you some acid-base imbalances, and these are terms that I listed on the top of that review sheet. And I really did, make sure you really spend a little more time defining these terms. They'll come up again in another slide or two, and I'll remind you of it. But we want to really be able to just define respiratory acidosis, respiratory alkalosis, and metabolic acidosis and alkalosis as well. Okay, and so like I said, once they come up again with a little more information on our sort of concept slide, so I'll talk a little bit more about those as well. So just some general concepts here. If we're talking about fluid and electrolyte balance, we have to mention the term homeostasis, right? So homeostasis is a general term, can apply to really levels of anything in the body, right? It's the idea that we have to always maintain this internal, steady state. And I'll tell you that that's not easy to do, right? So your body is constantly working to maintain homeostasis. And so for our purposes in this chapter, when we refer to homeostasis, we're talking about balance of fluid and electrolytes, okay? And so I told you your body's always working really hard to maintain that balance, okay? And so some systems that are involved, renal system, right? Your kidneys, particularly if you think about the functional unit of the kidneys, which is the nephron, okay? There are various hormones that will influence fluid and electrolyte balance, and we'll talk about those as we move through the chapter. And then, neural function as well, in terms of, inputs coming in and neural function being affected. Well, one, it's affected by acid. It's affected by fluid and electrolyte imbalance, but also, brain regions like the hypothalamus that will control the release of hormones that will affect this. Okay, so that's kind of where that's coming from. If we talk about electrolyte, these are, molecules that dissociate into ions in water. And so and obviously if you think about your body, your cells makeup, lots of water, right? So in particular, ions like sodium, potassium, okay? And again, those some of the terms that are listed on the top of that review sheet, right, refer to imbalances in sodium, right? Hypernatremia, too much sodium, right? Too little sodium, hyponatremia, and so on and so forth. So make sure you know the definitions of those terms as well. Okay, so we will talk about specific electrolytes or specific ions as we move through the chapter. Oops, sorry about that. Okay, in terms of fluctuations in fluid, right, meaning changes in fluid levels, and when we say fluid, we're really talking about water, right? It can lead to cellular changes, right? It can affect the electrical potential of cells. So, and then it can also cause fluid to shift into another compartment that maybe it shouldn't be in. And we're going to talk all about this. When you particularly think about electrical potential of cells, we're going to think about kind of, well, what happens if sodium levels or potassium levels are off? That is going to affect cells that generate action potentials, right? Like muscle cells, cardiac muscle cells, skeletal muscle cells, but also neurons as well. I told you that fluid and electrolyte balance and acid-base balance work hand in hand, right? So if you have alterations in pH, whether the blood pH or the cellular pH is decreased, right, becomes more acidic, or if it's increased, that can disrupt the function of enzymes, right? And also can disrupt the function of other proteins as well, okay? And can lead to cellular injury or even cell death. Okay, so again, if you take a look here, this is just giving you some ideas of neurologic alterations that can occur as a result of fluid, electrolyte, and acid-base imbalances, okay? Cardiovascular alterations, respiratory alterations. In respiratory alterations here, it's saying changes in ABGs. This is arterial blood gases. So we're talking about kind of measuring, right, oxygen and carbon dioxide levels. And if you want to get a little more information about arterial blood gas tests, you guys can take a look at this link here. I'm not going to click on it because I clicked on it in class, but you guys can take a look at that for a little more information on that. Okay, so this is now mentioning all those terms that you guys have in the beginning of your review sheet, right, that you guys looked up, okay? Also, gastrointestinal alterations, right? So these are kind of general alterations that are going to occur as a result of fluid, electrolyte, and or acid-base imbalances, okay? All right. Now, if you talk about, so again, now we're focusing on fluid and electrolytes. We're really not going to talk much about acid-base imbalances specifically, except that I'm going to mention it really kind of one more time in the next slide. But remember, that's chapter 9, and we're really not going to cover it. So all we need to know about acid-base imbalance is really what I sort of have told you already, and what I'm going to tell you on the next slide. Okay, so fluid in the body affects many different things, but here are just some main things that it can affect. Workload of the heart. And so if you think about an increase in fluid, right? An increase in fluid will cause an increase. Again, that's the typo that I forgot to fix. So let's fix it now. Okay. It will cause an increase in blood pressure. Okay. And there's obviously going to be more, the blood volume is going to be increased. The heart has to work harder to compensate for this increased amount of fluid. Also, if you have a deficit in fluid, the heart will have to beat faster to compensate for that. So both of those situations will increase the workload of the heart, okay? Various vital signs will be affected as well. So I just mentioned blood pressure. So depending on whether you have an increase in fluid or a decrease in fluid, you would have an increase in blood pressure or a decrease in blood pressure. Also changes in heart rate, like I mentioned here. And there's other vital signs that would be affected as well. If we talk about edema, and we're going to talk a lot more about edema as the chapter goes on, but edema is essentially, this accumulation of fluid, right? And like I said, we're going to talk about that more specifically. But fluid can leak out of the blood vessels, right? So if you have an increase in fluid in general or an increased blood volume, fluid will leak out of the blood vessels and can lead to edema. Also, if you have that fluid accumulating in the lungs, it can lead to obviously issues with oxygenation, okay? If you particularly think about concentration of electrolytes, as I mentioned on that last slide, it will influence electrical signals. So in particular, sodium and potassium, also calcium, these three are really important in electrical signals, okay, of both neurons and muscle cells. Also affect cardiovascular function. Cardiovascular function, if we think about the heart is a muscle, right? We have cardiac muscle tissue there. So electrolytes will affect the function of the heart, okay? So it says here in terms of elevated concentration through blood chemistry, or is evaluated through blood chemistry. So if you look at table 8.1, this is basically just showing you these electrolytes, right, that we are going to talk about and what their normal values are. Okay, obviously we don't need to memorize normal values. However, I could show you these normal values and say, here's the patient's value. Does that mean they have hyponatremia or hypernatremia? And then ask you about what symptoms they might have as a result of that, okay? Or something like that. Or what could potentially cause that or something like that, okay? Down here, serum osmolality is really just all of these put together, okay? It's basically a measure of how much water versus solute or electrolytes in total are in the blood, okay? All right, so if we look at this figure here, these concepts related to alterations in fluid and electrolytes, here's where we have a little more information on metabolic acidosis, right? And respiratory acidosis, and then both metabolic and respiratory alkalosis. Okay, so again, we need to be familiar with the information that's presented here, and also that I talked about on kind of the first slide. I'll give you a couple examples related to these in a second as well. So let's kind of leave that for last. But if we look at this, this schematic here, you can see at the center, we have fluid and electrolyte balance, right? That's what our chapter is focused on. We can see that this is closely associated with acid-base balance. And then we can see the other main concepts that are going to be affected, and then the sub-concepts out towards the outside, okay? So, again, things like perfusion. So we're talking about, effect or perfusion, and we're talking about cardiovascular system, essentially, effects. We're talking about elimination, right? Mood and affect, okay? Intracranial regulation. So fluid and electrolyte balance and acid-base balance can affect brain activity, right? And so can lead to seizures, can lead to coma if things are not maintained properly, okay? So again, I want you to understand that any imbalance, any fluid or electrolyte imbalance or acid-base imbalance is really dangerous, okay? So these are really dangerous alterations in physiology. All right, so like I said, we're not going to cover the acid-base balance chapter, so I want you to know these terms here. So if we talk about metabolic acidosis, okay, it says increased hydrogen ion concentration or decreased carbonate. Bottom line is, when you increase the levels of hydrogen ions and you decrease carbonate, you're decreasing pH, right? And it's becoming more acidic, hence the acidosis part of it, okay? There is a response from the kidneys to compensate for this in terms of retaining more carbonate, right? To keep that pH elevated. Also, the response that might occur due to metabolic acidosis is a respiratory response, where hyperventilation might occur to compensate again for this decrease in pH. Now, for metabolic acidosis, things like diabetes, there's something called like diabetic ketoacidosis. These are more metabolic acidosis would be caused by sort of nutritional / metabolic issues. Okay. So that was kind of my one example there. Well, I won't give you a whole bunch of examples, but you could look this up and to see what other things might cause metabolic acidosis. Respiratory acidosis, again, it's caused by increased levels of carbon dioxide in the blood. When you have increased levels of carbon dioxide, that leads to a decrease in pH. And so hypoventilation, right? Hypo, too little. Ventilation leads to increased levels of carbon dioxide. You have decreased oxygen levels, okay? Also, and so that would lead to respiratory acidosis, okay? So CNS depression, abdominal distension, these can all occur as well. Again, the kidney will respond, the kidneys will respond by increasing, again, production of carbonate here, because again, it wants to keep that pH elevated to where it should be, okay? It says here respiratory response, right, obviously increase. I don't know why, that's a typo. Sorry. Obviously, the respiratory response would be to try to increase oxygen levels, right? What's causing this is hypoventilation or some other respiratory issue, right? So if your lungs are not functioning properly, right, or there's something that induced hypoventilation or something like that, but usually this is due to some sort of lung function issue, right? You have increased levels of CO2, that's going to lead to acidosis again, a decrease in pH, okay? And again, there are compensatory mechanisms that would occur. If we talk about metabolic alkalosis, it's the opposite, right? So now you're going to have an increase in pH, okay? Again, kidneys will respond to try to fix this. For respiratory response, hyperventilation, right? It says, or hypoventilation. So bottom line is the respiratory system is going to, again, try to compensate for this change in pH, okay? A cause of metabolic alkalosis is actually excessive vomiting, okay? Excessive vomiting can lead to metabolic alkalosis. And again, the respiratory system will try to compensate for this, but then sometimes will actually lead to making the problem worse, okay? If you talk about respiratory alkalosis, now this is due to hyperventilation. So this means now you have decreased carbon dioxide levels and increased oxygen levels, okay? So things like anxiety can induce that, right? Pneumonia can induce that. Again, an issue with lung function could induce this as well. But a decrease in carbon dioxide will lead to an increase in pH, okay? So I want you to just know what these are, okay? So I think that's it. So I guess if you think about respiratory acidosis, right? Hypoventilation, more carbon dioxide in the blood. If you think about respiratory alkalosis, right? It is hyperventilation, right? Or decreased levels of carbon dioxide in the blood, okay? So again, acidosis means a decrease in pH, alkalosis, an increase in pH, okay? And so like I said, we're not going to talk more about these concepts. So I want you to just kind of understand in general what they mean. All right, let's move on now. Okay, the next concept we're going to talk about is total body water. Okay, so this TBW means total body water. Don't get confused because in a couple slides from now, it talks about total body weight and is showing you sort of percentages of these, of water compared to total body weight. Okay, but we're talking about total body water. That means if you look here, right, total body water is 60% in a 70 kilogram adult male. So that means a 70 kilogram adult male is made up of 60% water, okay? Or fluid, whatever. Now, this total body water or the amount of fluid that your body has will vary according to age and also amount of body fat. So fat actually contains less water than muscle. Therefore, lean individuals in general will have a higher percentage of fluid in their bodies or a higher percentage of water, okay? Also, younger individuals have higher TBW percentages. So, right? So 70% in newborn infants compared to 60% in an adult. Now, if you talk about, again, we're talking about body fluid, right? Or water. And so if you talk about where or how you then divide up that water, okay? So that 60% of your body that's made up of water, okay, can be divided across two categories. Intracellular fluid, which is exactly what it says, inside the cell. This is the largest portion of that total body water, okay? Most of your water in your body is actually present inside the cells, okay? But you also have extracellular fluid as well, right, called ECF. And you can actually divide that extracellular fluid into 3 other subcategories, okay? Now, again, like I said, intracellular fluid is inside the cells, okay? The intracellular fluid is the main component of total body water, okay? So about 70% of the total amount of fluid that you have in your body is inside your cells, okay? And it's composed of water, proteins, and electrolytes as well. Now, if you talk about extracellular fluid, that's outside the cells. And it says here sodium because predominantly the ion that's present in the extracellular fluid is sodium. Okay, so there is a high concentration of sodium outside the cell. This is about 30% of the amount of fluid that your body has. Okay, now you divide up this ECF into 3 different compartments or components, like I said. So there is an intravascular component. That's your blood, your whole blood plasma, and also lymph. So anything that's contained within a vessel, right? Whether it's a lymphatic vessel or a blood vessel. Next, interstitial component is the fluid that surrounds the cells and tissues, okay? And that interstitial fluid is a transport mechanism for nutrients, for waste products, and for gas exchange, okay? So when oxygen, right, or glucose moves out of your blood vessels, out of your capillaries into the interstitial space, cells can then pick up those nutrients and that oxygen, okay? Now you also have another component called a transcellular component. So this is fluid that's in defined spaces. So fluid like cerebral spinal fluid. Remember, cerebral spinal fluid basically flows throughout your brain and also spinal cord. It has its own sort of ventricular system within the brain, but also flows between the meninges that cover your brain and provide sort of shock absorption. Okay. Again, also CSF flows along the spinal cord. If you think about, somebody suspecting that you might have meningitis or something like that, which is inflammation of the meninges, you can actually take a sample of cerebral spinal fluid and test that for the presence of bacteria, right? To determine if you have meningitis. There's also certain joints that have fluid in them as well, okay? And body cavities is also another place where you'll find, or where we refer to it as the transcellular component. Okay. This figure here, again, is kind of talking about total body weight now, right? So it's saying, all right, in a 70 kilogram male, 60% of his total body weight is water. So that was the TBW that I said before, total body water, okay? Of that 60% of fluid, or water, right? 40% of it is intracellular, okay? Sorry here. Intracellular fluid is 40% of total body weight, okay? That's what this is saying. Extracellular fluid is 20% of total body weight, okay? That makes up this 60% here. So this is now showing you in terms of total body weight. Don't let this confuse you. The idea is just understanding that your body's made up of a lot of water, okay? And this is just giving you some ratios here. If you look at plasma is 5% of your total body weight. Interstitial and transcellular fluid, about 15%. So remember, the plasma refers to this, intravascular, okay? Interstitial and transcellular is this here. Okay. All right, now let's talk a little bit about movement of body fluid, okay? So concept called osmosis. And I kind of went through this in two different ways in class. I'll probably keep it simple here and just talk about what's pictured here. But maybe I might not be able to help myself. Anyway, when we talk about osmosis, it's really the movement of water, okay? So it says here, water moves from less concentrated to more concentrated areas to equalize concentrations, right? So the idea is it's moving across the membrane, right? From the intracellular fluid to the extracellular fluid and vice versa, okay? So I have written here too, this semi-permeable membrane represents the plasma membrane of the cell, okay? So these dots here represent some sort of solute, like sodium ions, okay? Sodium ions. So what this is saying, and what it says up here, is that water is moving from an area where there's lower concentration of these sodium ions to an area where there's higher concentration, because it's trying to balance out the concentration here. If you also want to think about water itself and the concentration of water, you can, right? So here, where there is less solute, there is actually more water, right? And so water will move this way because there's less water over here, right? So again, when you think about just diffusion in general, it's the movement of anything along its concentration gradient, right? From high concentration to low. So if you say osmosis is diffusion of water, right? Then you can say, all right, there's more water here. So water is going to have the tendency to move this way. Okay. So again, there's more water. Okay. So just to continue with this a little bit more, again, we're talking about osmosis, the movement of water. Okay. So when it's referring to lower concentration here, it means lower concentration of the solute. Okay. And then higher concentration of the solute, like sodium. All right. Okay, now if we talk about, again, diffusion in general is the movement of the solute, not water, okay? So molecules in general move from higher concentration to lower concentrated areas. So again, if we're going to consider these little dots as sodium ions, right, the sodium ions will have the tendency to move from high concentration to low, okay? And so sodium ions will actually move through that plasma membrane through special channels, right, through sodium channels. Water also does move through a channel as well, a channel called aquaporin, okay? All right. There's also examples of active transport, lots of examples of active transport in terms of things moving across the plasma membrane. So it requires ATP, that's where the active comes from. And in general, it's going to move molecules that are too large to diffuse, like proteins, across the membrane, but also will move ions against their concentration gradients. So that's what this is showing you here, right? Again, here's a sodium ion, right? Intracellular fluid versus extracellular fluid. There's a lot more in the extracellular fluid. It's going to require energy to move those sodium ions against their concentration gradient. They would normally have the tendency to go this way. So if you want to move them against the way they have the tendency to go, it requires energy, okay? Same thing, vice versa for potassium. And so this is kind of showing you, or sort of illustrating the sodium-potassium pump in a really general way. So there is a pump called the sodium-potassium pump that sits on every cell membrane that maintains that membrane potential. And basically it's called a pump because it requires energy and it moves sodium and potassium against their concentration gradients. Okay. And I sent this in class for this part, just try to I just want you guys to sort of understand this on the surface. I think this is kind of a difficult concept, but again, worth mentioning. So what I'm talking about here are two different types of pressure, okay? Something called colloid osmotic pressure, okay, or oncotic pressure. And this is essentially pressure that's exerted by the concentration of proteins like albumin, which is a major blood protein. And then there's something called hydrostatic pressure, which is just the pressure that's exerted by fluids, essentially fluids and their sort of electrolytes that are there, okay? And what this is going to pertain to is the movement of nutrients and gases out of the capillaries, okay? i.e. moving, oxygen and glucose out of the capillaries, and then the movement of waste products and carbon dioxide into the capillaries, okay? So on one end of the capillaries, the arterial end, and this is the end where you're going to have oxygen still in there, nutrients in there, because they haven't been delivered to the body's tissues yet, okay? There is higher hydrostatic pressure versus colloid pressure. And that allows or enables nutrients and oxygen to move from the blood into that interstitial space, okay? However, on the other end, on the venous end, okay, again, when we think about veins, right, we think about a picture that shows arteries and veins. Veins are always blue. Why? Because they don't have oxygen. They've already given off their oxygen to the body cells, okay? So the reason why at the venous end, waste products and carbon dioxides move into the capillary is because that there is lower hydrostatic pressure versus colloid pressure, okay? So I think, and I said this in class, I want you to kind of understand that this colloid pressure or this oncotic pressure has to do with protein levels. And so if there's something like malnutrition going on and there's a decrease in protein levels, other metabolic or disorders that sort of affect metabolism, maybe like diabetes, can also affect this as well. But if you have a change in protein levels, it can alter this oncotic pressure, and therefore it would interfere with this process that I just sort of described below, okay? This picture shows you this. It's saying here on the capillary, on the arterial end, right? The net movement is out. You have oxygen and glucose moving out, okay? And why? It's because that hydrostatic pressure is greater than the colloidal osmotic pressure in the blood, okay? Here in the middle, you really have no net movement because these pressures equal each other here. And then when you talk about at the venous end, your net movement is inside, okay? Because capillary hydrostatic pressure is less than the blood colloidal osmotic pressure, okay? So again, do you need to memorize this, guys? No, I guess I really don't want you to memorize this in any way, but because we're talking about fluid and electrolyte imbalance or balance, it's important to introduce this concept because if there is an imbalance of fluid or electrolytes, it's going to interfere with this process, right? I also gave you the example, if there's a change in protein levels in the blood, right? That can also influence this process, okay? So something to kind of keep in mind. And again, nothing that you need to memorize, right? Right. So I'm not going to really ask you a question about like, all right, at the venous end, which type of pressure is higher versus no. I want you to understand that, that again, those things that I just mentioned, or that fluid or electrolyte imbalance can actually interfere with this process here. Okay. All right. Now, one thing that happens as a result of fluid and electrolyte imbalance is something called edema. Okay. So what is edema? Accumulation of fluid, right? It says accumulation of interstitial fluid volume. Okay, there's a couple different causes. Okay, and again, you can see some of these terms that I just mentioned here. So some causes: increased capillary hydrostatic pressure. Okay, and this could be due to venous obstruction. And we actually will talk about this a little bit when we talk about vascular disease. But clots in the veins, right, can actually lead to edema. Okay, also heart failure, renal failure. Those are also things that can influence capillary hydrostatic pressure. And lead to edema. Increased capillary permeability, so actually damage to essentially to the capillaries, right, to the epithelium due to trauma or due to burns, can actually just cause fluid to come out of the capillaries because they're damaged. Okay, decreased colloid osmotic pressure, so damage to the glomeruli, renal disease. Okay, meaning, and I mentioned this right in the last slide. So renal disease, where you have some sort of problem with the glomeruli, and that will actually allow proteins to get through when they shouldn't. Also, again, protein loss due to malnutrition. Okay, you can also have edema happen if there is some sort of obstruction in the lymphatic system. Okay, also just excess body water and excess sodium. Okay, can happen, and this could happen as a result of decreased cardiac output, right, due to heart failure. Also just inadequate excretion of sodium due to renal failure. Okay, so these are all, here are some causes of edema. Okay, and you also can classify edema in different ways. So we can classify it as localized, right, generalized, and dependent. Okay, so localized is usually due to injury, infection, or obstruction. It's in a certain localized area. If we talk about generalized, usually due to things like heart failure, right? So you have this sort of uniform distribution, but it does tend to accumulate usually in gravity-dependent positions like feet and ankles, right? Like, so maybe your grandma has swollen feet and ankles. Sometimes that could be due to heart failure. Okay. Dependent. This type of edema is dependent on disease processes. So some sort of renal disease that results in excess fluid volume. There's also another thing that we can sort of use to describe edema. Okay. And it has to do with fluid spacing in terms of where this fluid is accumulating. Okay. So first spacing, okay, is normal intracellular fluid and extracellular fluid levels. Second spacing is excess accumulation of fluid in the interstitial space, right? And that leads to edema. Third spacing, okay, is actually fluid that accumulates in abnormal places. So like in the intestinal space, okay, so in the intestinal space where there's usually very little or no fluid, if fluid is accumulating there, it indicates an issue, right? So it could be caused by burns, again, decreased intake of proteins, right? Severe malnutrition, you see the bloated belly, that's because of this, okay? Also, you can get fluid accumulation in the peritoneal cavity due to cirrhosis as well of the liver. Okay, so some clinical manifestations of edema, okay, swelling. And again, you guys probably, you're doing this maybe in your clinical assessment class. That swelling or that accumulation of fluid can actually compress surrounding tissue and circulatory structures and lead to issues there. Again, what manifests clinically depends on where that edema occurs, right? So for instance, pulmonary edema can lead to shortness of breath and obviously, problems with, breathing and getting enough oxygen in. If you just think about edema of the extremities, it's more noticeable, it's more palpable. You can really assess it there. I mean, obviously pulmonary edema isn't going to be noticeable in a physical assessment, right? In terms of treatments for edema, diuretics, right? Diuretics basically cause your body to excrete more water. Also, IV solutions might be necessary as well. Okay, so if you look here, this is just pulled from the e-text here, right? This is grading pitted edema. So this is just showing you that you can basically assess it by sort of depressing in that that area of the body and to see what happens. So I'm not gonna, again, I'm not gonna be testing you guys on assessing this. This is what you're doing in some of your other classes. But I just wanted to make you aware that you can assess that. Okay. Now, how does your body regulate body fluids, right? So I told you that it's super important that fluid and electrolytes are maintained at homeostatic levels, okay? I think I also said that your body has many, many mechanisms to make sure that this happens, okay? So one thing we'll talk about, and I'll show you this on the next slide, figure 8.5, is this thirst mechanism, okay? So we'll go to that in a second. Yeah, so the idea, right? I mean, I guess, again, if you're not taking in enough water to begin with, obviously it's going to interfere with fluid and electrolyte imbalance, okay? So again, we'll talk about that thirst mechanism in a second. If you think about dehydration, right? In infants, it's actually going to be something that they're more susceptible to dehydration, okay? They can't tell you they're thirsty, right? They're an infant. They might be crying and you might not know why. Okay, so we'll talk a little bit more about that in figure 8.6. So I wrote here figure 8.6 is on slide 22. And obviously diarrhea or vomiting will potentially or can potentially lead to dehydration. Okay, and again, infants are going to be particularly vulnerable to this. Also, older adults, right, are more vulnerable to dehydration and imbalances of fluid. So they have smaller fluid reserves in general. They have reduced ability to conserve water. They also have a less acute sense of thirst, okay? So if we just look at this thirst mechanism, okay, this has to do with antidiuretic hormone. So this is showing you here. So if you have an increase in blood osmolality, and remember from that kind of, I don't know, it's probably the third slide in, we said all osmolality means, or blood osmolality, is basically a ratio or a measure of how much electrolytes or how many electrolytes or the ratio of electrolytes to water, okay? So if you have an increase in blood osmolality, it indicates a decrease in fluid, right, volume, okay? If you have a decrease in blood osmolality, there's too much fluid there or too much water, okay? So an increase in blood osmolality will trigger mechanisms in the body to get that osmolality back to where it should be, okay? So it says here, osmoreceptors in the hypothalamus. There's the hypothalamus again, okay? Those will be activated by this increase in blood osmolality, okay? Then it will stimulate the posterior pituitary, the pituitary gland, to secrete ADH, okay? ADH is antidiuretic hormone, okay? ADH increases distal tubule permeability, okay? So what does that mean, right? It means that it's going to cause the tubules in the nephron, right, to reabsorb more water. You want more water to be reabsorbed into the blood because, again, there is a decrease of water there, okay? Okay, so as I said, if there's an increase in ADH, right, antidiuretic hormone, this basically causes the kidneys, right, or the tubules in the nephron to reabsorb more water into the blood. Because again, this was induced because there was an increase in blood osmolality, meaning there is an increase in the amount of electrolytes that are in the blood, the amount of ions that are in the blood, and there's a decrease in the amount of fluid or the amount of water. And so the body needs to compensate for that by basically taking in more water, okay? And also another thing that will happen is you have a decrease in urine output. Obviously, if you don't have enough water in your body, you're not going to want to excrete more water in the urine, okay? Now, if the flip side is happening where you have a decrease in blood osmolality, so in this case, you have more water than you need, right? And a lower percentage of electrolytes. Okay, you would have suppression of ADH. If you have suppression of ADH, right, then basically you're going to have less reabsorption of water occur, right? And that's what this is showing you here. And you're going to have an increase in urine output because now, again, you have too much fluid there, too much water. So your body needs to get rid of some of that, okay? So that it can then get back to homeostatic levels, okay? So this figure 8.5 focuses on antidiuretic hormone, okay? And its action. Now, you'll see there are other mechanisms, again, that are going to affect fluid and electrolyte imbalance, but this is one that I want you guys to be familiar with. Okay. This is that figure 8.6 that's just showing you, again, you know, what that one slide was referring to was basically kind of these special populations, right? And that, you know, infants and children are going to be more susceptible to dehydration, okay? And so that's what this really is sort of showing you here. The other thing is to remember that, you know, infants and children actually have a higher percentage of total body water anyway. Okay. So if you look here, that this is, I don't expect you guys to memorize any of these numbers or anything like that. But again, you know, this is just kind of giving you some information as to why, you know, newborns, infants, and children are more susceptible to dehydration, right? And why it's important to really be able to identify signs of dehydration, okay? You know, a lack of, or a lack of fluid, right, caused by dehydration is really going to have pretty detrimental effects on infants and children, okay? All right. And again, it says here, kidneys are immature until 2 years and unable to conserve water and electrolytes or fully assist in acid-base balance. So again, this is why these, you know, younger children and infants are more susceptible to dehydration, right? And to changes in fluid levels. Okay. So a little bit more, again, in terms of regulating electrolytes. So this was more specifically talking about regulating body fluids, right? Because what is the antidiuretic hormone, the ADH, is basically affecting the amount of water that's going to be reabsorbed, okay? So that was focusing really on fluid levels. Now, if we talk about regulation of electrolytes, that's what this is focusing on here. So again, remember, electrolytes dissociate into ions. So if we're talking about positively charged ions, sodium, potassium, calcium. There's also negatively charged ions, anions, right? Like carbonate, chloride, and phosphate, all right? So if we particularly look at sodium concentration regulation, there are both hormonal mechanisms and renal mechanisms that are going to contribute to regulating sodium concentrations, okay? There are also peptides from cardiac tissue that will influence this as well, okay? The main regulatory system for sodium concentration is something called the renin-angiotensin-aldosterone system, okay? And this is figure 8.9. Oh, I didn't add in the slide number. It doesn't matter. It's in a couple slides, okay? We're just sort of, I guess, setting up for this. So I will explain figure 8.9 when we get there, all right? Again, if you talk about water regulation, we just kind of talked about that. ADH, antidiuretic hormone, but the concentration of sodium is going to influence the amount of water, okay? One thing to kind of just note here, there is a little article or an excerpt from an article, impact of nutrition on clinical practice, and it particularly talks about sports and energy drinks. Okay, it's on actually page 177 of your textbook. So something interesting to sort of check out. Okay, so you think you're going to drink a Gatorade to replenish your electrolytes. Well, that may not necessarily be helpful. All right, so check out that article if you're interested in that. All right, so this section, right, is particularly talking about water and sodium imbalances, right, in terms of what are some of the clinical manifestations and a little bit about the pathogenesis of it. Okay, so if we talk about we can kind of categorize or classify these different imbalances. So a volume imbalance or an isotonic imbalance means there's going to be equal alterations in both sodium and water concentrations, okay? So it can involve just a simple sort of increase in blood volume, right? Remember we talked about, like, if you have a decrease in fluid in the body, it decreases blood volume. So hypervolemia or hypovolemia, those are the terms to explain or describe an increase or a decrease in blood volume, okay? So it says here, sodium level remains normal in either imbalance, okay? So the idea is, again, that you're having increased water and sodium levels, or you're having a decrease in water and sodium levels. So it's kind of both of them are going to be impacted equally, okay? Now, remember again that sodium is the main cation or main ion in the extracellular fluid, okay? So normal levels are between about 135 and 145. If we talk about hyponatremia, it's below 135. Hypernatremia is greater than 145, okay? And I mentioned this already. Sodium really is essential for nerve and muscle cell impulses, right? Also, it combines with bicarbonate as part of the acid-base regulation. Again, further sort of giving you an example as to why fluid and electrolyte imbalance will affect acid-base balance, okay? All right. So again, if we're going to talk about, again, water balance, okay? So again, this is what we're talking about. If we talk about the effects on red blood cells, and we talked a little bit about this, I think, in lecture. So if we talk about isotonic versus hypertonic versus hypotonic, okay? This refers to the osmolality of essentially of the solution, okay? That the cell is in. So it says here, if inside the cell, right, it has the same osmolality as the body fluids, then we call that isotonic. And in this case, if we're talking about red blood cells, right, in an isotonic environment, they're going to be perfectly happy because really the movement of water into and out of the cell is balanced, okay? If we talk about red blood cells in a hypertonic solution, okay, that means that you have this sort of this increase in, right, hypertonic, the solution essentially kind of, or outside the cell, is going to have more solute. The osmolarity is higher. If that's the case, that's going to cause water to move outside the cell and can cause these red blood cells to shrivel up, okay? If we talk about a hypotonic, right, meaning, again, that osmolality is actually lower than body fluids, right, than they should be, meaning you have more water outside the cell. More water is going to move in, and actually, if too much water moves into a red blood cell, it can actually cause it to burst, okay? Both the shriveling and the bursting are really dangerous to the red blood cell and can cause that cell to die, okay? So if we kind of continue now, again, if we're talking about isotonic fluid volume excess. So again, it's this idea of this sort of equal increase, okay? So it says here, increase in extracellular ECF sodium levels or hypervolemia. Remember, hypervolemia is an increase in blood volume. Again, leads to sort of excess fluid levels. We talk about clinical manifestations, weight gain, decreased plasma proteins. Why? Because again, we have this increase in fluid and sodium levels, and that's going to decrease plasma protein levels, okay? Distended neck veins, increased blood pressure, okay? Increased capillary hydrostatic pressure that then obviously and also can lead to edema, okay? If we're still continuing on talking about fluid volume excess kind of in general, in terms of diagnosing it, you might see decreased hematocrit, meaning decreased red blood cell levels, decreased blood urea, nitrogen levels, so urea levels in the blood, high cardiac output. These are some things that you would notice in terms of diagnosing this excess of fluid volume. Treatment, restrict fluid intake, and then obviously to correct that underlying etiology, right? So there's obviously something, or there's most likely something causing this, okay? So obviously important to correct that. So what are some potential causes? So diseases like Cushing's disease, which actually leads to an increase in other glucocorticoids as well, but an increase in aldosterone can cause this excess of fluid volume. Also, renal failure, heart failure, just excessive IV fluids that are given or excessive sodium intake can actually lead to this as well. Okay, so important to correct whatever that underlying cause is. Okay, now if you talk about on the flip side, right now we're talking about an isotonic fluid volume deficit. Okay, again, symmetric depletion of water and electrolytes. Okay, so you have a decrease in both. Some clinical manifestations: decreased urine output, weight loss, increased hematocrit, because again, you have decreased fluid volume, tachycardia, decreased skin turgor, decreased blood pressure, and potentially could actually lead to hypovolemic shock. Again, hypovolemia means decreased blood volume. That blood volume, if it decreases enough, can actually lead to shock. Okay. Again, if we talk about a little bit more about the deficit and we look at diagnosis, okay, some of the same factors we talked about before with increased volume, right? So you'll see an increased hematocrit, you'll see an increased urea, essentially urea to creatinine ratio, so an increase in urea. Urea is basically formed by the breakdown of proteins, right? And so basically it's sort of this waste product that's produced that's normally gets secreted out in the urine, okay? So if you don't have enough fluid, it's not excreting it, then you're going to see these levels increase. Increased serum osmolality, increased urine osmolality. Again, all osmolality means is that you have more electrolytes there, okay? Increased specific gravity. Again, it has to do with the ratio of solute that's in the urine, okay? Treatment: increase oral fluid. You may have to do IV rehydration. Causes could just be vomiting, diarrhea, right? Burns, excessive sweating can cause this, okay? If you look here, this table 8.2 actually shows you, and we mentioned some of these clinical manifestations in the last couple slides, but I think it's nice to kind of see it in table form. And it actually also, this table will put side by side fluid volume excess and fluid volume deficits, right? So in terms of blood pressure, if you have an excess of fluid volume, it's going to lead to increased blood pressure. Think about it. Fluid volume excess, higher blood volume, increased blood pressure. If you have deficit, it's going to lead to decreased blood pressure, okay? Heart rate increased in both cases, okay? Pulse, okay? Respirations. You guys can check out all of these different clinical manifestations here, okay? All right. Now, to talk a little bit more about sodium imbalances in particular, okay? And then I will probably cut it off there, and then I'll put up a part 2 for the rest of it. So what we talked about in the last couple slides were increases in fluid levels and electrolyte levels to the same degree, right? So you just had an overall increase of fluid and, say, sodium, or an overall deficit in fluid and sodium. So we called that sort of isotonic increase or deficit, okay? Here now we're particularly focusing on sodium imbalances, okay? So aldosterone, okay, is a hormone. It's a mineralocorticoid that's actually released by the adrenal gland, the adrenal cortex. And it is part of this system. So remember I mentioned this system before in terms of this is sort of the main regulator of sodium levels, okay? So it's called this renin-angiotensin aldosterone system, or RAS, okay? So we'll look at it on the next slide. It gets activated by a decrease in blood pressure, okay? So if there's a decrease in blood pressure, it will activate this system, okay? So in general, again, what's going to kind of trigger it? So secretion of renin will lead to sodium retention and increase fluid volume, and then therefore will increase blood pressure. Okay, so we're going to look at that on the next slide. There are also peptides, and I think I mentioned these before too. These are peptides that are actually produced by the heart. Okay, so atrial natriuretic peptide and brain natriuretic peptide. Okay, these from the atrial cells of the heart and these from the ventricular cells of the heart. They actually will be released in response to elevated atrial pressure, and they serve to really turn off this system, okay? So the reason why we're mentioning them is because they're going to interact with this system. All right, So if we take a look at this renin, angiotensin, aldosterone pathway, again, it's saying here, liver constantly produces this, essentially this protein, this angiotensinogen, okay, in the plasma. So that's around. So the angiotensinogen is in the plasma, okay? If there is low blood pressure detected, it will lead to the release or the production of renin, okay? Once renin meets this angiotensinogen, it produces angiotensin 1, okay? Then this angiotensin 1 gets converted into angiotensin 2, okay? There's an enzyme that converts angiotensin 1 into angiotensin 2, okay? What angiotensin 2 does in the plasma is actually it leads to vasoconstriction, okay, of arterioles, and obviously will increase the blood pressure. So if it constricts the arteries, it leads to an increase in blood pressure. Also, it leads to release of aldosterone, okay? Aldosterone will lead to an increase in sodium reabsorption from the kidney. And therefore, that will also lead to an increase in blood pressure. But remember, we're talking about, this is really talking about regulating sodium levels, okay? And this whole pathway is initiated by a decrease in blood pressure. So the end result of this pathway is to increase blood pressure, okay? Aldosterone is, its effect is to increase the levels of sodium in the blood, which then will increase blood pressure as well, okay? So it's sort of doing two things, right? This angiotensin 2 will lead to vasoconstriction, but it will also lead to the production of aldosterone. Aldosterone will lead to an increase in sodium reabsorption, right? So we'll increase those sodium levels, and also that will affect blood pressure as well. Okay. So again, that is the main regulatory pathway for sodium levels, okay? We should be familiar with that. Again, do we need to memorize every step in this pathway? No. I think if I'm going to ask you a question about this, specifics of this, I would show you the figure and ask you about it from there. Should we know that the renin, angiotensin, aldosterone system is involved in maintaining sodium levels? Yes. Okay. All right. So hypernatremia, again, we went through this term at the beginning of of our review sheet, is a increase in sodium in the blood. Okay. There is a table 8.3 that I'll refer to in a slide or two that shows you signs and symptoms of both hypernatremia and hyponatremia. Okay. So too much sodium, and too little sodium, okay? So again, if we're talking about hypernatremia, sodium concentration greater than 145, okay? Causes increased output or decreased intake of water, right? So again, if you have decreased intake of water, or you have increased urinary output for some reason, it's going to lead to higher levels of sodium, okay? Also, increased sodium consumption obviously would cause this. Other things like burns, heat stroke will affect sodium levels as well, okay? So again, some clinical manifestations, hyperosmolality. What does that mean? Your osmolality of the blood is increased in general. Fever, dry membranes, hypotension, tachycardia, pulmonary edema. Also, there are CNS symptoms that can happen as a result of hypernatremia as well. Okay? In terms of diagnosis, again, you can look at serum osmolality. You'll see that there are increased serum sodium, and also just sodium osmolality in general is increased. Increased urine-specific gravity. Again, all-specific gravity is sort of a ratio of the amount of solute that's in the urine compared to water. In terms of treatment, again, if there is some underlying etiology, you got to fix it, right? If it's just a result of too little water or too much sodium, you want to decrease that serum sodium levels. Maybe you need to give hypotonic fluids. If this is caused by something like diabetes insipidus, right? Insipidus, if I could say it, you would have to actually give synthetic ADH. Okay, so this in diabetes insipidus, basically the body is not able to regulate how it handles fluids. Okay, and so it's caused by a decreased production of ADH, okay? And so you need that ADH to regulate fluid levels, okay? So it is not related to diabetes in any way, all right? So it's in little extra info in my notes there. Okay, now if we talk about hyponatremia, okay? Sodium concentrations are below 135. What are some causes? Vomiting, diarrhea, diuretics in general, right? Taking diuretics basically will increase urinary output, right? Other diseases and conditions like Addison's disease, right? So Addison's disease, again, it's adrenal insufficiency. So those hormones that are produced by the adrenal gland are not being produced. You know, we mentioned a couple of them already. We mentioned aldosterone. Then your body is not going to be able to maintain fluid and electrolyte levels, okay? Clinical manifestations, neurologic effects, hypotension, tachycardia, right? Decreased urine output. If I could spell decreased, okay? All right. In terms of diagnosis, again, this is all kind of the same thing over and over again. So that's why I kind of told you, I think I told you guys this in class, maybe I told you it now, you know, you're going to have to kind of take this in doses, okay? Because we're going to go through the same thing for calcium, for potassium, okay? And you're going to see there's going to be similarities. Okay, so anyway, for diagnosis, right? Decreased serum sodium. Obviously, we're talking about hyponatremia, okay? But also usually there's decreased chloride and bicarbonate levels as well, okay? Increased hematocrit. Again, we're talking about now, you know, an increase in those red blood cells. Low urine specific gravity, okay? In terms of treatment, if it's mild, you can give an oral sodium replacement, okay? If it's moderate, IV fluids may need to be administered. If it's severe, you're going to need to give hypertonic fluids, okay? But you have to be careful with that. If you're giving hypertonic fluids and then you induce hypernatremia, it's going to obviously be a problem, okay? All right, so if you look here, this is actually figure 8.10 on the right, and this is figure 8.3 on the left. So table 8.3. So again, table 8.3 is just outlining signs and symptoms of both hypernatremia and hyponatremia, okay? And some of these were listed in the slide, but again, it's nice to kind of look at these sort of side by side, okay? Now, this is basically an overview, okay, showing you sort of, okay, here's normal sodium concentrations in the extracellular fluid, right? Homeostasis, that's what we're trying to achieve. It says here, what happens if the body detects increased sodium levels in the extracellular fluid, right? This will stimulate receptors in the hypothalamus, lead to secretion of ADH, okay? ADH will restrict water loss, right? And basically promote water consumption, okay? Here, if we're talking about decreases in sodium levels, okay? Again, hypothalamus will lead to a decrease in ADH, right? And again, it's going to basically cause that decrease in ADH, anti-diuretic hormone, would lead to more water to be released, okay? And so if you have decreased sodium levels, that suggests, right, that you have higher levels of water. So you want to get rid of some of that water so that now you can restore those normal sodium levels, okay? So this is really just showing me we kind of did this in another way. This is kind of just showing you it, I guess in a different way, right? But this really is what we just went over here. All the way back here, okay? This antidiuretic hormone. Because again, antidiuretic hormone, just like it says, antidiuretic its job is to basically keep water in, right? It's going to cause more water to be reabsorbed in the kidneys, okay? So if you have more ADH around, more water is going to be reabsorbed. Your body's going to hang on to more water. If you have less ADH around, right, your body's going to excrete more water, right? More water in the form of urine and get rid of it, okay? So again, what this figure now is showing you is sort of relating, right, sodium levels with sort of water levels, right? And saying, okay, if you have an increase in sodium, Well, that means you want to also bring those water levels up to compensate for that, so you can bring it back to homeostasis. Okay? All right, guys. So I'm going to stop there because obviously it's already been an hour. I will upload this part 1, and then I'll also put